honestly, this is a game changer, right? I mean, when you see how poorly these patients typically responded to existing systemic therapy options, it was really demoralizing, right? I mean, patients were dying. And I think we're able to see a better response, no question, with, bevacizumab and erlotinib. So that's really encouraging. Congratulations to your team. Was there something that what do you hypothesize would be the difference between, the response rates between sporadic group as well as the HLRCC group? They're both papillary. Obviously, there's different reasons and genetic reasons why, but what would be the reason that they would have a reduced response?
Yeah, so we know that based on some of the rationale we talked about earlier, these FH deficient or HLRC associated RCC are more sensitive to these agents. I mean, if you look at clear cell kidney cancer, we tried this combination before. Bevacizumab and erlotinib had really modest outcomes, 13 to 25%. And when you added erlotinib or took it off, it really didn't make that much of a difference.
Yeah.
So it really was the biology of these tumors, especially those ones with the biomarker of that FH deficiency or that HLRCC showed us that there was a response there. But there were, of the patients that responded with sporadic papillary RCC, they had similar median duration of responses, which is around 18 to 19 months. So there are some similarities. There is a group of patients there that when they respond very similarly to our HLRCC patients. And that's part of the ongoing work that we're doing right now, trying to find different molecular characteristics to identify this. We have some theories, but there are certain pathways that may make these more similar to what we expect from HLRCC and sensitize these patients to combination. So follow-up study is being done right now, but honestly, to understand what are the patients that respond to this and what are some phenotypes, and can we extrapolate that into other studies as well?
Sure. I mean, I think maybe what you're saying as well is that sporadic group is not as homogeneous as we would expect it to be, right? It's probably a group of heterogeneous patients, and their characteristics may be a little bit different, but yet more to come in that regard, right? We just don't know.
Yeah. At the time when the study was first started, we still had that designation of type 2 papillary. So we saw this wastebasket term. As we're going back and looking through it, we see a number of papillary type 1s and a number of more undefined. Now they'll be less defined. They're no longer papillary type 2. So they likely have different phenotypic and molecular characterizations. And that's what we're trying to find out. It's a very heterogeneous group. So figuring out which one of those are sensitive, as opposed to very homogeneous HLRCC tumors, can help us identify it and better make sense of what's going on in this basket group.
I think the study was great. Obviously it was able to be published in one of the highest impact factors, but I think the journals with the highest impact factors. But what I think also highlighted, at least to me, and hopefully we can highlight a little bit more, is the importance of the NIH and how we can take these relatively rare diseases from all over the country, all over the world, bring them to the NIH and actually be able to give them treatment. And so that's kind of the role the NIH plays, right? Is to be able to take these rare diseases versus academic centers all over the country or world see maybe a few of these every year, if at all. And so we're able to concentrate all of that in one place and actually get really usable and durable data to help benefit patients. And I think that's really a kudos to the NIH team, and congratulations to your team on this.
Thank you so much. And I agree with you. It's great to have these tertiary quaternary centers or referrals so we can gain this data. But obviously the whole point is to democratize this data, make sure that people in the community can use this information, help make decisions, because there are a lot of people who can't travel here or they can't do it. And it's just important to have the care there. And when you look back from the 90s to now, about 10 years ago, we looked at the overall life expectancy of patients with VHL. It's improved by 16 years in a very short time frame. And I credit a lot of that work to to Dr. Marcin Linehan, who helped establish the gene, et cetera, and a number of people who worked with him during this time, and a number of people throughout the country who've really helped kind of understand this disease and understand the syndrome and condition that a lot of patients are going through. And so it just moves forward. And I think we're hoping to add a few more years to that, especially as we go on, further on, that, this becomes more of a global effort. And we're seeing that a lot more now.
I'm sure we will. So, just to kind of close off, I think we had a great conversation about hereditary kidney cancer and what the future is. Help me understand from your end, what are you most excited about in this hereditary kidney cancer space? And, what's pumping you up now?
Yeah. So there's some things we didn't get a chance to talk about earlier. Two things from the hereditary kidney cancer space. There's a follow-up study that's actually ongoing right now. We know that from HLRCC, we know that these tumors are sensitive to immunotherapy. And so there are a number of studies, both here at the NCI and other places, looking at checkpoint inhibition along with TKIs.
Hmm.
Another multi-center study currently led by the primary principal investigator, Ram Srinivasan from the NCI, assessing bevacizumab, erlotinib, and atezolizumab as triplet therapy with the intent to see deep and durable responses. So I'm really kind of awaiting that study in the upcoming few years. One of the things that we didn't talk about as much, but in the setting of VHL, we have agents now that over the course of a number of different trials, et cetera, have finally come to FDA approval. And the one I'm
Hmm.
talking about is belzutifan, HIF2 alpha.
Belzutifan. Yeah.
Exactly. And it's really been a game changer for a lot of patients. The surgical burden, lifetime surgical burden of going through neurosurgery, pancreatic surgery, kidney, Fios, et cetera,
Yeah.
eye surgery, it's just a lot for a lot of our patients. And this has given a respite for a number of them and can avoid and hopefully reduce the overall number of surgeries they need in their lifetime. So we've opened the doors now with belzutifan coming through, and now we're seeing other agents come through in this space and other avenues and other companies and investigators interested in looking into how we can medically manage some of these tumors as well to improve their lives. So there has just been opened. Strategies are still developing on how best to utilize these medications in patients with VHL and localized tumors. So there's a lot more to come from here as well.
Awesome. Oh, we're really excited, and we're looking forward to seeing what else your team's going to have in the years to come.